AFib, and stroke, and we're everything to bring it home here. So 116.4 million, or 46% of US adults have hypertension or high blood pressure, right? I'm in that group. 1 in 5 adults, or 22.5% of American adults, don't get enough exercise. I think I'm in that group. 1 in 6 males and 1 in 7 females are current smokers. These are all issues that bring on stroke. And the estimates that American Heart Association has right now is by 2035, a little bit over 45% of US population will have some version of cardiovascular disease. So they're all the things that bring on our enemy, stroke. So we're on the stroke one.
What do you want? What do you want? We have no idea where you're at.
10. No, it's got an old guy.
I said it doesn't look anything like Addie.
Yeah, so I was like, it can't be right.
Doesn't this guy remind you in that movie of the man that stood there like this? Was it Roadhouse? Remember he got beat up? He was the... Does anybody remember that movie?
I love Roadhouse. It was a great movie.
Who was the old man that stood in the front like this with one leg and had to fight everybody? He was the...
That I don't remember.
I'll think of his name. It'll be tonight, you know.
Right, midnight. Here we go.
So the American Stroke Association, it's all about preventing stroke. So and we're at the international conference because just like HIMA is trying to get international, the American Heart Association, the American Stroke Association is trying to bring this home internationally. They picked Hawaii, and I think next year's in Los Angeles, but they had a huge international presence. Because a lot of the things we do here in the United States, just like the American College of Surgeons, is their benchmarks are used internationally. So it's interesting. So stroke is the #5 killer in the United States. So this is big news. It's the leading cause of serious disability. So how do they improve care? They give the medical teams tools and resources with the latest and greatest scientific treatment guidelines. So there are resources as well. Well, we'll get to it. But the data that's collected, those 2,000 or 200, whatever it is, 2,000 hospitals that have 2 million records put into a database, that data, a statistician who could very well be an HIM person, it's not always a nurse, goes through that data and determines, you know what, this subset of antibiotics that is given within X amount of time from a stroke turns out to be significantly more effective. So next year we're going to say that's the standard. You know, Xarelto, it wouldn't even be antibiotics, but blood thinners. You see on TV, warfarin and versus Xarelto versus all these different meds. This is what we're talking about. So patient education. There's actually a heart care channel in the hospital. So if you had a stroke or you're on a telemetry floor, one of your channels is a heart care channel where you can sit there and watch it. So today I was at the cardiologist because I have AFib, and which they can't find again, which I'm proud of. But sitting in the waiting room, you're watching the heart care channel from the American Heart Association. So it's just interesting. That's one of the things that they're doing, one of many things. So now we're with the clock. All right. So 220 people approximately per 100,000. This is 2016's data. Death rates are attributed to cardiovascular disease. Every 38 seconds, somebody dies of cardiovascular disease. This is in the United States. Every 40 seconds, somebody in the United States has a stroke. This is big, big, big. It's big news. It's big bucks. It's growing. It's an industry that has big room for HIM. Not everybody has to be a nurse or a physician. Everybody dies of stroke, or somebody dies of stroke in the United States about every 3.7 minutes. So now we're with the heart and the dollars. So get with the guidelines, stroke is an in-hospital program for improving stroke care. It promotes consistent adherence to the latest scientific treatment guidelines. It's 5 million patient records. I don't know, I think we said 2 million earlier. So there's about 4,800 hospitals in the United States of America. About 2,000 of them already participate. So I think this started in 2003. So there's about 5 million records in there already. So if we're looking at the treatments from 2003 to the treatments in 2018 that we had at the 2019 conference, we're seeing major improvements from the treatments that they've done. And this is how almost all the registries work. The surgical registries work, all the different trauma registries work, tumor registries work. All of this is collective data to be compared to increase your outcomes across the board. Very interesting. So I understand the coding side and everybody wants to be a coder, but believe me, look at Addie, right? And Addie, I think, has her CPC, right? But she ended up on this side. So there are measurable patient outcome improvements. We've been talking about it. I can't bang that home enough. Stroke is a major public health concern. Direct costs of strokes. They're estimating this past year, 50 billion, and indirect costs are 35 billion. Who wants to give me an example of an indirect cost of stroke? Direct costs would be meds given, hospitalizations. What would be? Think about somebody that has a stroke that needs what?
Lost that time at work.
Well, I was thinking about rehab.
Occupational
How about getting a ride to rehab and back?
How about the caregiver?
The caregiver. So this is huge. Remember, it's the number 5 killer. So now we can leave the heart. Okay. So this is what happens. So I want you as HIM professionals, when somebody says, oh, we're a Get With The Guidelines hospital, or oh, you see that they won the J.D. Power Award, or you saw they won this award, well, when they say that they're a comprehensive stroke hospital, or they ranked here for any of the cardiovascular stuff, this is how it works. So the hospitals say they're Cerner or Epic. So there's an import that comes out of Cerner or Epic that goes into, I think they call it collector. It's their data collection software. I forget it. Is this one called Collector? Does anyone? Collector's Trauma. Okay, this is something like that. Whatever the patient management tool, PMT. So there's the import that comes across, but then there's the actual abstractionist. And let me tell you how these imports work. The team that does the import never really is there. No offense to any IT people in the room, and no offense, you really need the clinician that does the data collection to help with the import. So I have personally seen imports where we're looking for apple, a red apple, the data cell, and the import went and reached out there and was mapped to something red, and we got fire truck. Well, the red fire truck isn't what we need, so it's garbage. So a lot of the imports that come across, you have to validate before you go any further. So they usually have a minimum of hard cells for, let's say, demographics and labs that you can determine. A blood gas between here and here. That we can capture and bring across. But don't be looking for all this fancy stuff, not yet, because you're not going to find it. So then the abstraction piece happens. So in abstraction, the way it's done for the American Heart and Stroke Association is there's one pass. So say all of you are the abstractors on that account. Production pass, everybody gets 10 charts. Okay, so that's production. The second pass is you had some fallouts, things that didn't meet the American Heart Association and American Stroke Association's guidelines, such as aspirin wasn't given within so many minutes of the stroke. So you had one chart that did that. That's going to be re-reviewed by you to make sure that you didn't miss it anywhere. So we looked at the fallout, but it may not be your fault. It may be you couldn't find it. Maybe it wasn't in the record yet because you didn't scan it in yet because you were using one of their students to put it in. And 1,000 reasons. Right. So whatever, but we want to correct that fallout, but we don't want to take the data and manipulate it. We want to report exactly what happens because we don't want to say it happened and it didn't. We don't want to game the system. So if you do find that it was scanned in, or scanned in the inappropriate folder and you couldn't find it and now you found it and everything is good, wonderful, the fallout was turned over. But now you've said it's not there, and you've said it's not there. Well, now it goes on an outlier report and it'll go to somebody in quality management, or it may not be quality, it could be any different place. It could be the neuroscience team across the board, whoever it goes to. But now that needs to be addressed, why aspirin wasn't given upon arrival or within 20 minutes because it came from like a smaller rural hospital to a comprehensive stroke hospital. It's very detailed. So, and then what happens is monthly, we're gonna do probably 10% of all your records and look at them just for inter-rater reliability to make sure that you understand that you can collect from these 3 different tabs that aspirin, because maybe you only think you can collect it from one. So there's inter-rater, there's production, there's fallout, and there's inter-rater. So there's 3 passes. This is how data, well, CPHQ would teach you this. So the quality reports are generated. You look at risk-adjusted mortality reports and patient-level reports. So everybody understands, does anybody not? I'll explain it to you what risk-adjusted mortality means. Okay. So here's the deal. Jared's young and healthy. He's 31 years old. Just say, we all know that I'm 53, I'm overweight, I'm hypertensive. Let's just say we'll add diabetic on top of it. And we'll throw in, let's give me something else.
What else do you want?
Give me another.
High cholesterol.
High cholesterol, thank you.
Okay.
So we're comparing this, but now both of us had a stroke. There are many reasons that he could have a stroke. Many, many reasons that he could have a stroke and normally perfectly healthy. So the risk-adjusted piece of this is not just for mortality, but it's for outcomes. So we have to adjust the fact that I'm older, that I have hypertension, high cholesterol, overweight, diabetes. So that's the risk-adjusted reports that then come out. Because it's not fair, because what used to happen was your hospital used to say, well, I have a bunch of nursing homes by me, and my patient population is all 90 years old, and this is why my reports look like crap. And he lives in the healthiest place where everybody jogs, runs, and plays tennis. That used to be the way it is, but now these reports adjust for mortality and just for all the risk-associated factors. This is something I want you to take away because I'm teaching you. Am I not? This is like CPHQ class. How am I on time?
Data analysis, but you only listen to me half the time.
Well, I jump around and stuff.
Okay, just kind of.
So,
back to Charlie Brown.
So Julia needs to jump around more, is what I just learned.
So you benchmark the hospital to all the hospitals that are adjusted to it, and you can also benchmark it, say, in your health system or by region, because that has a lot to do with it. You can't look at Buffalo, New York, and Phoenix, Arizona sometimes. You can't. So the systems at the American Heart Association, American Stroke Association, also have point-of-care education materials. So if I develop another symptom while I'm admitted, and the caregiving team can say, you know what, not only does the caregiving team get education, but there's patient education materials that'll zap out of Cerner or Epic or whatever to start on the patient for treatment. Who knows if that patient's sneaking down to the, I don't know, somewhere and hiding and smoking cigarettes while they're in the hospital, or not, their sugars are out of control and they're drinking juice boxes. Their daughter's bringing it in and you don't know. So, and then we talked about fallouts, integrators, and outliers. So what happens is all the hospitals are doing is, one, they want to affect their patient population to increase, they want to have better outcomes, because once you have better outcomes, your cost to treat those patients goes down right away. This is proven. So now they have lower cost to treat their patients, they have better outcomes for their patient population, and now in that region, Cigna, Blue Cross, think of all the different payers, they're going to want to send their patients to that hospital, right? Because they have lower costs, risk-adjusted, lower costs to treat stroke patients. So if you have, they call it a hub and a spoke. So you have the hub hospital and in very dense areas, they're comprehensive stroke hospitals. There's a bunch of them. But you have, so that's the hub of the wheel. Picture a wagon wheel, right? So I'm talking about all the spokes that go out to the hospitals that may have a lower credential, right? They have to transfer to the comprehensive stroke. So that hospital might say, for all those patients that are with Blue Cross, they have to be transferred to this hospital because they have better outcomes and lower costs than that hospital. So that's what all those awards mean when they're advertising on TV. So now we're on the one with the certificate.